So, good morning everyone, and thank you for coming to the session on the economic costs of dementia. I hope that's the session that you are all here for. If it's not, you're in the wrong room. So I'm really delighted to be able to introduce this session. I think the economic costs is an issue and one which is of great interest to associations, to policymakers. It really is one that when people are talking about dementia and talking about policy making, that is the question that always comes up is, and so what is the cost? So I'm really delighted to be able to have these five presenters today presenting on different aspects. There will be time for questions at the end, hopefully. The speakers know they have to keep to time. And when we have questions at the end, just a reminder to the audience that this is a hybrid session. So we do have people joining us online, so welcome. So if you do get the microphone to ask a question, please speak into it because it's not just the people in the room who need to be able to hear you, it's people online as well. So without any further ado, I would like to invite Laura Philbin up, who's going to talk about the economic costs of caring in Ireland, the impact of the cost of living crisis on family carers and taking action to address it. Thank you.
Hi, good morning. So I am Laura. I'm the Research and Policy Manager at the Alzheimer Society of Ireland. So in Ireland, there are over 180,000 informal carers of people living with dementia, so caring for a family member or for a friend. And the value of this to the state is estimated to be in the region of €804 million per year. And I think what we need to remember is that caring in Ireland has long been associated with poor health outcomes like stress, burnout, loneliness, isolation, and that's even when we were at our most affluent during the Celtic Tiger. And to put this into context, the prevalence of clinical depression among family carers of people with dementia in Ireland is 3 times the national average. So since the end of 2021, Ireland has been experiencing a serious cost of living crisis like many countries across the world. And this escalating cost of living crisis is now exposing a vulnerable cohort to even more stress and de-stress due to the cost of care, this is rising, and due to a reduced ability to work. So social protection research-related advocacy is actually very new to the Alzheimer Society. I am very much not a health economist, so I don't really even know what the word econometrics and things like that mean, but we really saw in our grassroots that people were struggling with the financial costs of caring, and we felt that we just have to take some action now to address this. So what I'm presenting today is actually our first kind of move into this area in Ireland. We're very lucky as well. We're fortunate that we have other organisations and strong relationships with people who are very well versed in this area, such as Family Carers Ireland and St Vincent de Paul. So how did we get started? Family Carers Ireland is a charity that represents over 500,000 family carers in Ireland, and this is, children, people with a range of illnesses and conditions. And they were doing some research in 2022, and as part of this, they collected financial information from family carers, and we worked with them to extract the data that was related specifically to people living with dementia, just to kind of get a first look into what's going on for people who are caring for someone with dementia, and we produced this report on it. So the results were stark. We had 129 people. The majority were caring for parents, and around 1 in 5 were caring for a spouse. So 55% said they're having difficulty making ends meet. And actually, this is maybe kind of an Irish thing. So basically, 55% of people were struggling to, meet their expenses. 12% were actually having great difficulty making ends meet. 18% said they're cutting back on household essentials like food, electricity, keeping the heating off. And 23% have cut back on seeing friends and family. And this is really important because I think we all know that seeing friends and family, doing your hobbies, they're the very things that can keep us well, particularly when we're in a stressful situation. And actually what we found was the majority of respondents, so around 77% of people actually felt that their value as a carer or their role was not recognised by society. And if we go back for a minute, €804 million per annum is their value to society, but they feel like they're not recognised. So there's a big issue there. And in some cases, their financial difficulties were so stressful that they were falling behind on their mortgage repayments. They're not able to keep up with their energy bills. And we made recommendations from this report, and I won't go into detail because they're very specific to the Irish social protection system, but essentially what we asked for was increased and sustainable financial supports for family carers, help with rising energy costs, that's our biggest challenge, and also to recognise the cost of caring, so things like sanitary ware, fuel, diesel, when making decisions about financial support. But basically, after writing this report, we knew that we needed to go deeper and look more into what is impacting family carers, and also not just the financial pressure, but how are they feeling about it. So this brings us to the experience of dementia in Ireland, a snapshot in time. So this was a national piece of research that we conducted, and it was across a range of areas, so service access, health, communities, looking at kind of all of our previous work. And what we really wanted to do as part of this was also to learn about the financial cost of caring. So we collected the data in May and June 2023, so just a few months ago, and we had 597 family carers take part in this research and 72 people living with dementia. So 308 people said that they were involved in the financial aspects of a person living with dementia's life. So 50%, very similar to the previous study, 50% reporting difficulty making ends meet. 11%, again, great difficulty making ends meet. And then 36% of carers actually needed to make work adjustments. So they either stopped work, they had to reduce their working hours, they had to change their hours, and almost 1 in 3 spend more than 80% of their time caring, and this is around 134 hours per week. So when you think about the amount of time someone is spending caring, how are they able to work as well? We'll get there. So what we found then, statistics are great, and actually something I've learned from working in the Alzheimer Society is the media love a good statistic. If you want your work in the media, lots of statistics. But we're really interested in the humans as well behind the story. So carers describe difficulties with, as I said, keeping up with their mortgage repayments, bills, buying food. Many were relying on loans from family members, they're eroding their savings, and a lot of them report consistent worry and guilt about their own future, but also many of them have young families because they're caring for a parent, and they were worried about their children's future. They felt like they were spending money that should be for their children on the person living with dementia. And just to say that this issue is not, people living with dementia are not causing this problem for family carers, it's the lack of financial supports provided by our social protection system. And the rising cost of living actually goes really hand in hand with the rising cost of providing care and support to someone with dementia, and these effects are being felt deeply by family carers. So you'll just see a selection of quotes there, but one that really stood out to me was a person said that she couldn't continue to visit her father who has dementia quite as often because of the cost of diesel. So that person living with dementia is not getting the support that they need, and the family carer is feeling guilty because they can't go and see them, but it's literally down to an economic cost. Then financial challenges, what we really found is they're intensifying the stress and the burnout and the worry and the health challenges that people are already experiencing. As we said, many are reporting on cutting back on socializing, hobbies, and what they deem to be these non-essentials, but as I said, they're the things that keep us well, they're the things that keep us going in hard times, as we've all learned, I think, during COVID-19. So both of these research studies clearly show that year on year, carers continue to experience financial hardship, intensified stress, worry, and anxiety on top of their caring role. So one of the great privileges of working in the Alzheimer Society in research is that you actually get to kind of see it turn into action, because we have an advocacy team and a communications team, and that's one of the really, really positive things. So we're very invested in evidence-based advocacy in the Alzheimer Society of Ireland. My colleague Clodagh Whelan is our advocacy manager. So in Ireland, we do our budget once a year. I think that's kind of an unusual thing, but it's a whole thing in October. So every year, ourselves and all of the other charities create a campaign where we ask the government to invest in dementia services and supports for people living with dementia. So for the first time here, you'll see social protection actually appeared in our pre-budget submission. Then we managed to get this news of the financial hardship of family carers into 3 separate news cycles. So we had our first report, we had the launch of our pre-budget submission, and we had the launch of our Experience of Dementia in Ireland report. So news, radio, really getting it out into the public domain that this is something that we need to think about, and also working with other charities and collaborators. For example, and this political advocacy is really important. For example, all of these reports were in the inbox of every politician in Ireland. So they knew exactly what was happening. We briefed political representatives, we have information on our website, press releases, and we actually had our budget there last week or the week before. And I was nearly kind of worried about this part of the presentation, because what we asked for was an increase of €27.50 for the carers' benefit or carers' allowance, and now they only increased it by €12. So this still represents actually a real-time cut when you think about inflation and the cost of caring. And I was thinking, oh, is it going to look like, these efforts failed? But actually, they haven't failed, because we've actually stepped into this space now. We've put the advocacy, we've put this kind of research, and we've put this financial hardship of family carers onto public record. And now we look forward to continuing our advocacy work in that. So I just have the pleasure of presenting this work today, but it's actually really thanks to Ms. Clodagh Whelan, Dr. Diana O'Doherty, Ciara O'Reilly, Dr. Nikki Dunn, and our fabulous PPI contributors, Ms. Janice Nolan-Palmer, John Crowley, Ms. Alison McCarthy, and also to St. Vincent de Paul. So the reports are available on our website, and if you have any questions, I'd love to hear them. Thank you very much.
So thank you so much, Laura, for that really interesting presentation. I think the ability to have as you say, everyone loves a good start. It makes a really easy way to communicate the issues facing carers, and I think to have the balance of the statistics, but also the personal experiences that you shared as well, is really impactful. Does anyone have any questions in the room? Would anyone like to ask Laura anything about the reports or about their campaign, their work? I should have actually taken the iPad as well for the online questions. So I don't see any questions in the room. In that case, I would just ask you to say thank you to Laura again, but a round of applause for the excellent presentation. Thank you so much. And I will move on to our next speaker, who is Soeren Mattke from the US, who's going to talk about closing the gap, the estimated investment needed to increase England's capacity to deliver an Alzheimer's treatment to G7 average levels and implications for wait times. So the floor is yours.
Okay. All right. Good morning, everybody. Still slightly jet-lagged coming here from Southern California, so forgive me for being a little hoarse. I'm talking today about closing the gap. Like, how much would NHS England have to invest to get at least to the G7 average spending levels? And that is an interesting question, because England has long been at the forefront of sort of political leadership when it came to Alzheimer's disease, with sort of ambitions like becoming the most dementia-friendly country on earth by 2025 or whenever that was. But that tended to contrast with a NHS that's actually creaking at the seams, right? Years of underinvestment, laid bare by COVID. So we wanted to look like how close is England with these great ambitions actually to even be sort of average among the G7 countries. So here are my disclosures. So the background to this story is that the arrival of disease-modifying treatments, of course, creates a substantial challenge for health systems. We have an enormously prevalent disease that has mostly not been diagnosed at all because there was limited therapeutic consequence from diagnosing it. And we have this very, very large prevalent patient pool. So as the first disease-modifying treatments now become available, there's this enormous backlog of people that have never been formally diagnosed, and then hitting a pretty much unprepared healthcare system because this ecosystem hasn't had time to evolve. The problem is particularly hard for countries that have comparatively low capacity to begin with. And so we wanted to know, how does this look for NHS England? This was a combination of desk research, so we got a lot of data on how many specialists like geriatric psychiatrists, neurologists, geriatricians are in NHS England, what are their working hours, how many visits do they do, to estimate like how many people could they actually see if these treatments become available. Things like PET scanners, MRI scanners, facilities for lumbar puncture and so on. And then we have cost data that like how much does this actually cost to increase capacity. And then we use a Markov, a simulation model to estimate how long people will have to wait at status quo, and then how long would people have to wait if you increase investment and get to G7 average. So this is the baseline, and this looks pretty dire. So we have the G7 countries here up, and then the England values down and below. And you can see the NHS has about 40% of the average capacity of the G7 countries when it comes to things like dementia specialists, PET scanners, has about a fifth of the MRI scanners of other G7 countries, like 20%. That's clearly disturbing. And the reason for this is this little number here, 0.4%. That is the percentage of GDP that, in this case, the UK spends on capital investment in healthcare, right? So it's not, the NHS or the UK spends a relatively large proportion now of GDP on healthcare, but the money doesn't go into infrastructure. The money goes into mostly salaries. And that was quite surprising to see because in the Blair years, the government raised spending from what was well below G7 levels to pretty much approaching G7 levels, but it didn't factor into investment. So you can see it's 0.4, G7 average is about 0.7, so it's about half of what other countries spend. This change doesn't really factor through in a year or so because you can always push back investment, run this ancient MRI scanner 1 year longer, postpone renovation of a hospital facility. But if you keep doing that for a decade or two, it really shows. And that's basically behind these numbers. And that factors through in wait times. So this is the projection over 20 years, wait times in months on the y-axis. And you can tell how long people would have to wait to go through the diagnostic process for a disease-modifying Alzheimer's treatment. And these are really disturbing numbers. Like we are getting up to 10 years, mostly because people wait for their specialist appointment. The short wait, this is the yellow little thingy above that, the short wait for biomarker testing, keep in mind, is not because there's an abundance of PET scanners and lumbar puncture facilities. It's basically because people are held up. They're not getting their first appointment that would generate the referrals for such tests. So once you shrink the wait times for dementia specialist visits, the yellow bars will increase. So here's what it will take to get at least to G7 average. The headline number is 13.8 billion pounds over 10 years on average, so spread out, fully inflated and whatnot. And the biggest chunks is actually not in fixed costs, so increasing number of PET scanners and MRI scanners, that's sort of about 4 billion, so it's about a third, but a lot would have to go into the variable costs, like additional specialists, additional nurses to the lumbar punctures, and that would increase capacity to do these tests quite a bit, as you can see. And it would also factor through. So this is, if you remember the picture from a few slides ago, here we talk about 10 years. And here we talk about pretty tolerable wait times, right? You start with the initial influx at about 30 months, but it then comes down pretty quickly to sort of reasonable times in people having to wait. And as I explained earlier, this also means that people will have to wait longer for their biomarker test, but mostly because they're getting seen faster by a specialist. So Of course, there are limitations. This is simulation, this is not real numbers, and we combine a lot of published data, but we also use a lot of expert information, because some things you just don't know, right? Like what proportion of neurologists are actually able to provide a diagnostic evaluation for early stage Alzheimer care. There are some things that we just couldn't count, right? We did know from data the cost of the building modifications to put these big devices, MRI and PET, into existing facilities, but sometimes this just doesn't work. You have to build something new, and we did not know what that would take. Non-financial obstacles, like you can't 3D print dementia specialists, right? You need to hire them, train them, and that takes a lot longer than just kind of investing. On the flip side, we are having changes in technology like blood tests, digital cognitive tests that could actually ease the burden on the delivery system. So some of the numbers might come down. But keep in mind, these things are an area of active research. That doesn't mean that we have them and have them approved and covered by NHS any day soon. So for the time being, that pessimistic picture actually holds. Okay, so overall, long-standing underinvestment in the NHS would likely lead to very long wait times for diagnosis to receive a disease-modifying treatment in England, up to 10 years. I mean, seriously. And that is really, really counter to the NHS guarantee to get a specialist diagnosis and access to treatment within 18 weeks of referral. So there's a really, really big gap between aspiration and reality. There does need to be a targeted investment to actually reach even the average of G7. And that would actually make a big difference because the baseline situation is so poor. Yes, technology will help. Clearly, we are getting better at diagnosing at scale. But again, this is not something that we will have right away. And we have to keep in mind that the cost of inaction is also large, right? There's the bankable cost of putting people into care homes, but there's also, as the previous speaker has explained, the burden often unmeasured on caregivers. So it's not just an expenditure for the government, there's also a real benefit of doing so. And for those of you taking pictures, this paper will be out really soon, so you can get all these graphs and numbers downloaded at much better quality. So, thank you very much. Happy to take questions.
So thank you so much for that really interesting presentation. I think especially when it comes down to, we talk about the need for, timely diagnosis and to get, an accurate diagnosis. And I think you've shown really clearly there that, especially in the case of England, that that's not at the level and that the resource needs to be put in to make that a possibility, both through, MRI scanning, but also through investment in the NHS. Does anyone have any questions for Soeren?
Hi, thanks so much for this presentation. I have a question about the wait time analysis. So does this reflect, you said it's all on published data, and of course there are a lot of unknowns and you needed to use expert opinion, but is this currently reflecting the current situation, or is this in the case that these biomarker-based drugs come available and then there needs to be testing for them to get access to the drugs?
It's the latter, because right now, very few people with especially early stage dementia and or Alzheimer's disease are even sort of picked up or let alone diagnosed. Paradoxically, the later stages are of course diagnosed because the symptoms become hard to ignore. And at the same time, interestingly, a lot more diagnostics is done in moderate and severe dementia, even though the therapeutic consequences of knowing the exact etiology are quite limited. So it's kind of the other way around as it should be, and we will have to flip to be much faster in early stage and early stage accurate diagnosis.
Thanks for this presentation. It's real worrying figures that you presented, and you talked about the context of infrastructure that we need once there are drugs, the MRI, the PET scans and so on, and that's a blind spot in many countries. Media and policymakers focus on the drugs themselves, but we're hearing like they're going to cost like 25,000 euros per year per person. You did not take into account those costs?
No.
And why not? How would that change the picture?
It doesn't change the picture. It's just without that investment, you don't even have to worry about the cost of the drug because they are not even getting on treatment. I mean, I don't think the drugs will be as expensive in the US, in Europe. They never are for some reason, but they will be expensive. And not necessarily because the price per patient is that high, because if you look at other things like oncology or immunology, the price per person is actually much higher than what you see for the current price of, say, lecanemab with 25,000. I mean, Humira, which is an anti-inflammatory drug that should have been off patent for a couple of years already, is about 3 times that. And that's kind of for autoimmune disorders. The problem is the number of people. So it's the budget impact and the fact that we have an extremely prevalent condition in the elderly that makes policymakers worry. It's not the cost of one person, it's the number of persons. But it's sort of a difficult question to say, well, if you have a common disease, we don't treat it because it could get expensive when we have sort of no inhibitions to spend hundreds of thousands for cancer cases, which individually are not that expensive, but as a group are also very expensive. But that's just me. So.
Okay, last question.
Hi, good afternoon, Dr. Mattke. My name is Sophie Lou Axelson from Stockholm, Sweden. I was wondering if you can please elaborate a little bit more on the early detection software or technology that you would like to see in place. I'd like to share one case study of a memory clinic in Stockholm, Sweden. They've had a 150-person queue that was blocking up the system. They initiated one software and they cleared it up in 2 weeks. Karolinska Institute, it has 280 people waiting for some kind of action, and they've extrapolated a model that says like they're not going to be able to address it or clear up that queue until 2027 if nothing changes. Mm-hmm. So I would like to have your perspective as to what you would like to see as ideal, safe, scalable, implementable early detection. What is in your, Wizard of Oz? What do you think we should be having so that it's something that we can all take with us? Thank you.
Of course, that's a very good question. So for starters, we need relatively robust, easy, scalable, and cheap screening tools at the primary care level, because right now we've just published a paper. The detection rates in the US and probably also in other countries of early stage disease are dismal, right? So we don't even have the problem of wait times because they never get there. So we need tools that are more accurate than the common tools like Minimental or MoCA, but don't require like 15 minutes to sit down and score. Like digital cognitive assessments that are reasonably precise, to avoid what's also a problem with the Minimental, a relatively large number of false positives. Right? The specificity of these tests is only about 75% and change. And that doesn't sound too terrible, but that means 25% of the 50 plus, 65 plus, whatever you have your cut is, population will be false positive and sent to a neurologist. And that basically kills the system because 25% of the full population, that's just a lot of people that actually don't have a cognitive problem and still get sent forward. So if we can bring down that number, we are in a much better shape. Also, if we get blood tests, obviously, for the Alzheimer's pathology, we can be a lot more targeted. We've done a paper a few years ago that the wait lists almost disappear if you, is that my signal? If you introduce a blood test and triage based on a cognitive and a blood test, such hard triage is probably not going to happen, but it can tell us that if you have a reasonably accurate blood test that you can say, well, I mean, we have no evidence of cognitive impairment, early stage, no positive blood test, so this could be a disease-modifying treatment candidate. That person gets into a fast lane as opposed to somebody else. It's also the flow, because right now people are sent to a neurologist with very little information. Right? They come with subjective memory complaints, stuff, and then the neurologist has to start from scratch. Okay, history, basic labs, MRI scan, talking to family, and that all can be done before somebody comes into the neurologist so that he gets, like, or she, a nice dossier and can see, okay, no stroke, no vitamin deficiencies, pretty fast progression, early onset, looks like Alzheimer's, even a blood test. So let's get that PET scan or lumbar puncture quickly, because that person has a limited window to get treated with a drug that can actually change his or her life. Easy said, hard to do.
Thank you so much, Soeren. Can we have another round of applause for a really excellent presentation and the questions? Thank you so much. So our next speaker is Bethany Anthony, who's going to present on the topic of an online pre-death grief and loss programme for carers of people living with a rare dementia, a microcosting analysis of the road less travelled. Thank you.
Thank you. Good morning, everyone. My name is Bethany Anthony. I'm a research officer at the Centre for Health Economics and Medicines Evaluation at Bangor University. And today I'm going to talk to you about a study I've had the pleasure of working on with colleagues